With Professor Mararovic with their works in journals for sport medicine, Deutsche Journal for Sports Medicine, as well as British Journal of Sports Medicine, and they give the first principles of ultrasound examination of musculoskeletal system. We can evaluate by ultrasound location of the anatomical structure, echo structure, shape, size and volume of interested structure, relationship to surrounding tissues, demarcation, vascularization by power Doppler techniques or Doppler techniques, and certainly also compressibility, soreness, adhesions. What's a very big advantage of ultrasound, that we can do dynamic examination not only by moving the probe but also by moving the part of the human body. So by ultrasound we can image, we can understand ultrasound as a part of clinical examination, not only as a method to image the tissue. Use of ultrasound should be in real time, that means directly. Post-processing, that means we can show pictures, and invasive techniques, that means ultrasound guided invasive functions or operations. Certainly a part of ultrasound examination is also data storing. At first it was plain photography, now it's electronically directly putting the data into the computer. What's very important, that bones we can visualize from the surface, not in the depths, so the ultrasound picture look like this, and that was the problem why ultrasound was going so slow to orthopedics. But the surface is very precise, especially when we use high frequency probes, and we can see the healing of the fracture. The fracture is directly visible on ultrasound, as well as the healing processes. Here you can see the colors, the place where the fracture was happened. Next possibilities are also in forced position, so we can see bony surfaces, and in forced position we can see the differences between distances in quiet position as well as in stressed position. So these are two methods for examination of the ankle. The first one is method according Ernst and Coates from Germany. We can measure anterior telar drawing test. In this moment we measure the quiet position because between the tibia and talus. Another picture on the right hand side is the measurement of ventrolateral approach, is our own, and in this moment we can distinguish the distance through talocrural as well as subtalar joint. So if we do this two examination, we can distinguish if the instability is in talocrural or in subtalar joint or bones. So it's harmless without negative side effects, so it's better to use ultrasound than X-ray examination. Ultrasound can be helpful also in such diagnosis like osteochondromas. It's till now typical example for X-ray examination, but ultrasound can give us also the information about cartilage surface and growth potential of osteochondroma, and we can say, okay, here is the cartilage too high, and the growth potential of osteochondroma is also high, or there is no cartilage and it's only exostosis without any growth potential. It's very important for surgical treatment. Soft tissues certainly are the target of ultrasound examination. Now we use the high resolution probes between 13 and 22 megahertz routinely in musculoskeletal ultrasound, and as you can see, we can see any fiber in the tendon. Moreover, we can see vascularization of the region. Here is the pathological neovascularization of Achilles tendon. So it enables us to use correct treatment with sclerotization later on. So we have here a question about 3D. 3D is a millennium technology. It started in the beginning of this century, and first discussion was on ISMUS Congress in Stratford-upon-Avon. That time, Professor Graf said that 3D ultrasound picture should be like a translucent glass globe, and we can see inside what's necessary. So the reality is certainly every examiner should do his own 3D picture in his brain. That means by rotating or tilting the probe or moving the probe. But certainly we try to transfer this possibility also in electronic form. We must change our mind in the examination. The smallest piece of the screen is one picture element, pixel. But from the 3D picture, it must be the smallest cube. That means volume elements. And when we have the whole cube of these voxels, we can catch the 3D picture. And more, we can cut this cube and have infinity possibility of cuts, but normally we use the coronal or frontal plane. So now modern devices can do automatically the 3D scan. There are special probe which the linear probe is moving, and strictly parallel pictures prepares the sequencer for the 3D picture. The sequence looks like this. So, sorry, Professor Graf, but from these pictures it's very difficult to prepare the globe, translucent globe. That's why we modified a little bit your possibility, and we use the glass block. And from this glass block, we try to cut our knowledge and pictures. From this translucent glass block, we can see the information. This is so-called transparent mode. We can see inside the block and cut it, certainly. But we can also model the structure inside by space reconstruction and surface mode. So this is the interesting area of image. Certainly nowadays also the small portable machines can do 3D pictures, but the work with this picture is a little bit problematic, especially the cuts through this picture is difficult and not very precise. We can use the cutting the cube step by step in basic planes, means longitudinal, transversal, and horizontal. This is the example of the Baker cyst, and we can see inside all what's inside the cube. But for routine examination in quick time, it's a little slow possibility. This cube we can cut also like this, but it also takes time. That's why we use another possibility of direct imaging, and it's multiplanar image. There are in one moment in the screen 3 perpendicular planes, and when we move with the crossing point, we can see directly the place of interest. Certainly, it's very nice when we can see all these planes together, but the space reconstruction is missing. this moment we know that's a calcar calcanei. This is Achilles tendon, pre-Achilles bursa, and this is the calcar. This too, but how it looks in spatial reconstruction. We can cut away all soft tissues, and in this moment stays only the bony surface. And now we can model by ultrasound the bony surface like by CT scans and bone modeling. So ultrasound is able to do also very big work with bone surfaces. Soft tissues, as I said, is a target of our interest. So this is modeling of space modeling of insertion of Achilles tendon. Here it's by automatic volume scan. Here it's freehand scan, and that's a mathematic wire model of this Achilles tendon. What's new? New is that we can model also in 3D panoramic view, that we have only one probe, and we move this probe for a longer distance. It can be, for example, 30-50 centimeters, and we put into computer all these sections, and we model in 3D panoramic view. That means new modal step. We are not, our place of interest is not given by size of the probe, but with the trajectory of the whole probe. We can do it freehand or with special trolleys which moved the probe on the skin surface. Here you can see the calcaneus, small calcar. Here is the Achilles, here Achilles rupture. In the longitudinal view, here in transversal view, here is the shape of the rupture of Achilles, and here is the transversal cross-sectional cut. Invasive techniques. We are starting this era of sonography. Certainly are very important for the future, for macro-invasive operations. Nowadays we use mostly ultrasound guided punctures, and sonosurgery is now very quickly developing. This is so-called 4D ultrasound guided punction. You can see the needle in multiplanar form of image. There is the perpendicular crossing, but this all is doing in so-called 4D mode. This 4D means that the fourth mode is the time modality. So that's 3 dimension in the space, and the fourth is the time. That means it's real-time puncture in 3D. Certainly, the ultrasound-guided puncture is very elegant. We can use also it not only for evacuation and taking samples, but also for instillation of drugs. So it's very often used, this type of ultrasound techniques. On opposite, here you can see the installation of etoxysklerol, that means sclerotization of pathological neovascularization of Achilles tendon, as I spoke in the beginning of my lecture. Certainly, sonosurgery is very important. Nowadays, mostly we use ultrasound-guided biopsies, but the world is open to ultrasound-guided sutures, tenotomies, revisions, and so on. So, but we cannot forget the comparison between another modalities of imaging method. That is the correlation with X-ray of the bone tumor. On the left-hand side, you can see the spiculi on the X-ray and also spiculi in ultrasound imaging. In this right-hand side picture of both are osteosarcomas, In the right hand side you can see here the Codman's triangle of periost, and here is the same picture on ultrasound. So we can see that the correlation between both methods is very, very good. Certainly also MRI is very important, but ultrasound can bring us very good information about the vascularization of tumorous tissue in the examining field. New modality, nejde nám to video. New modality is so-called CEUS, it's contrast enhancement ultrasound, enhanced ultrasound. We use the special contrast materials that contrast is given by small bubbles. That's why also bubble contrast. Zkuste to dát bez té obrazovky. Just a moment. I'm sorry. I hope that we will see the picture in a moment, so I will comment it before. So the more vascularized parts are better fused by this contrast materials, and we can see directly this contrast agent going to the place of interest, and in the end there are the crash of the bubbles, and we can see very nice the pathological structure. In special cases where it's difficult to distinguish by ultrasound between normal and pathological structure, can bring this contrast ultrasound very new information. What does he say? So he tried to improve the video sequences. So this is the possibility of data storing of ultrasound picture. We can store the whole cube of information. That means we can examine the same patients later on as a virtual patient, and some years ago to repeat and control the whole examination of the region of interest. This moment doesn't work, nothing. So I'm sorry for technicians, that's technical problems of them. So I have to say that it's necessary to come back to help me. This doesn't work, nothing. So now we are able also to use new techniques to have pseudocolours. So pseudocolours we put mathematically to grayscale, and it enables us to distinguish pathological structure. That's one new thing. Another new thing is also so-called histoscanning. That is a mathematical method developed by Briel-Kier, and it's used routinely in that machines, and that's the evaluation of tissue distortion. This is a very new method, especially valid for tumorous structure, because normal examination by ultrasound examiner is approximately to mine 10% information of the ultrasound picture. With histoscanning, this information very rapidly is increasing. So in the end, we can go back to the sports medicine. Very good advice. Use ultrasound only together with clinical examination. The validity is increasing very good, because otherwise the false positive and false negative results are very often. These mistakes and artifacts we can have objective that are given by the method and machine, and subjective by mistake of the examiner. So, to say in the end, we can that ultrasound is subjective and a little bit problematic. It's not specific, it's very sensitive, cheap, and ecological without negative side effects. So, I think I'm sorry you cannot see the contrasound and hands, but maybe later on. So, thank you for your attention. So